So hello everyone and welcome to this month's CRAE webinar and our first webinar of 2022. We really appreciate you taking the time to join us today. For those of you who are new to CRAE, and as a refresher to those who are more familiar with us, my name is Laura Crane and I'm currently the Interim Director of the Centre. And CRAE is the Centre for Research in Autism and Education, which is based at the newly titled UCL's Faculty of Education and Society, which is at University College London in the UK. And at CRAE, our goal and our ethos is to conduct autism research, but really importantly, we aim for our research to be on topics that matter to autistic people and their allies, and that actually make a difference to autistic people's day-to-day lives. And we feel that one of the best ways to do this is to meaningfully involve autistic people and their allies in designing, in developing, in conducting, and in sharing research. So we take a really participatory approach in all that we do. And we're also really committed to making sure that academic research on autism is shared beyond academics and that everyone can engage with both our work but also that of other research teams. And that's one of the reasons that we set up our CRAE Webinar Series. So we want to showcase the work of leading autism researchers and advocates in the field to a really broad audience. And at this point, I'd like to say a particular thank you to all of our funders and supporters and team members who make these events possible, and especially to the Pears Foundation, who really generously support our work at CRAE and without whom these events wouldn't be possible. So that's a little about our centre and our values. And now I'm going to move on to welcoming our wonderful speaker for today's webinar. And I'm absolutely thrilled to be able to introduce you to the phenomenal Dr. Cathy Leadbitter today. Cathy is a research fellow at the Division of Neuroscience and Experimental Psychology at the University of Manchester. And the reason that we invited Cathy to present today is because we genuinely feel that Cathy is doing some of the most brilliant research in autism at the moment. And if you haven't read Cathy's recent paper in the journal Frontiers on how to revolutionise early autism intervention research by embedding principles derived from autistic self-advocacy and the neurodiversity movement, I just cannot recommend it more highly. It's just brilliant, as is all of Cathy's work, quite frankly. And that's why we're really happy that she's here today to talk to us about our work. So thank you, Cathy, for taking the time to deliver the webinar. Now, if members of our audience have any questions for Cathy, you can either put these in the Q&A, or if you prefer to post them anonymously, there's a website called Slido, and we'll put the link to that for anyone who wants to use it in the chat. So thank you once again, Cathy, for delivering our webinar this month, and we look forward to your talk on an evidence-based, ethical and person-centred care pathway for autistic children and their families, asking how can we make this happen? Over to you.
Thank you so much, Laura. I am just posting some links into the chat, just because these are links to things I'm going to be talking about in my talk. So it's just good for people to have those in advance. Just let me also share my screen and make sure that I'm sharing the right screen. And just to say thank you so much to you, Laura, for your very kind introduction. And as you know, I am a great fan of your work and the work of CRAE, and it's therefore a huge pleasure for me to be here today to give this webinar. So thanks so much for the opportunity. So this is the title of my talk, an evidence-based, ethical and person-centred care pathway for autistic children and their families. How can we make this happen? And this is such a crucially important topic. And it's also a massive topic, really very broad. And I did want to do it justice today. So I think my talk is going to be slightly longer than can be fitted within the 1 hour slot, to make sure we've got a decent amount of time for question and answers. So I've discussed that with Laura, and we're okay to stay on a bit beyond the hour, if we need to make sure we can have a nice discussion at the end. So my talk today focuses on children and families, as this is where most of my research has been situated. And I want to say that, of course, there's a whole other talk or two needed about pathways for autistic adults, where there are arguably, even larger gaps in provision and in the evidence. So I just want to acknowledge that before I start, because, although I am focusing on children and families, I'm not disregarding, the situation that there also is for autistic adults. So today I'm going to reflect on the current situation of clinical provision, mainly thinking about the UK to start with, and then present a framework for the direction we need things to move in and some of the fundamentally important issues we need to be engaging with. And also present some of the research progress that we've made over the past couple of decades, with a particular focus on two projects that I've been involved with. Not because I'm holding these up as paragons of research excellence, but more because they're examples that I'm very familiar with, and I do think I can use these examples to exemplify some of the issues that I'm going to be talking about. And just to say that I've provided some links in the chat for some of the papers and the projects that I'm talking about today. So where do I start on this broad but very important topic? And I wanted to start with two statements, really, which act as fundamental beliefs, fundamental assumptions, really, that underpin my work and will underpin the talk that I'm giving today. And these statements are that autistic people can lead healthy, happy, and fulfilled lives. And autistic people enrich society and the lives of those around them. And to demonstrate these statements, I want to introduce you to a friend of mine. You can see him in the pictures here. So this is a friend of mine, Rory. I'm sharing his pictures and story with permission. So I used to work with Rory when he was a preschooler. He's in his early 20s now, and Rory's autistic. He has learning disabilities and has a lot of support. Now, as you can see in these pictures, Rory loves music and dancing. This is him having a boogie at the Latitude Music Festival last year. Rory also loves running, and this is him doing his 200th park run. Rory, in many ways, lives a very fulfilled life. And you can see in this picture here, what a valued member of that park run community he is. And we shouldn't need to justify these statements, but sometimes the message can be so doom and gloom, and the statistics around mental health and so on for autistic people can be quite shocking. And so I like to reconnect myself with these fundamental values, really. And whenever I find myself wobbling on these two assumptions, I can rely on Rory's mum to post a picture of him on Facebook, open water swimming or skiing or something like that. And it snaps me out of my doubts, and and it reminds me of these two fundamental beliefs. Okay, so the next three statements. So it's definitely true to say that life is not always easy for autistic children and their families, and sometimes life can be really quite difficult. And there are huge barriers in place sometimes to autistic people, autistic children, being able to lead their best lives. And help and support is needed to help children and families to remove or overcome some of these barriers. And many families need and want, and indeed are begging for, help to understand, connect with, and support their autistic child. And finally, autistic children and their families have a fundamental right to support. This is stipulated within the United Nations conventions ratified by the UK. It's also stipulated within our NICE guidelines. So care for autistic children is not an optional extra. It's not a nicety. It is a basic fundamental right. Okay, so let's start with thinking about autistic children and their families and what support needs to look like. And I'm going to say some pretty obvious things here, but sometimes I think they do need saying. So if you were to take a sweep of the autism intervention literature, you might well be forgiven for thinking that autism only affects young children, maybe 2 to 5 year olds, and that the needs of those young children are all the same. And that a fixed period of intervention, you know, maybe 3 months, maybe 2 years, is the solution to their care. You know, we clearly need a change of tack. Support for autistic children and their families needs to be long-term. Autistic preschoolers turn into autistic children, turn into autistic teenagers, turn into autistic adults. And the needs of autistic children and their families change over time. You know, the needs of this little girl sitting on the stairs here are unlikely to be the same as this young woman in the photo on the right. So a one-off programme of intervention is not going to do it. Support needs to be episodic, so it needs to be there for when needs arise as a child grows up. Care needs are also multifaceted. You know, it might be communication, it might be sensory needs, it might be sleep, it might be anxiety. You know, one intervention in addressing one thing is not going to cut it. And also, autistic children are hugely diverse. You know, families are hugely diverse, and their care needs are also very diverse. And a one-size-fits-all approach, you know, is also not going to cut it. You know, we need services that are flexible, person-centred, and that can be adapted to individual needs. Okay, so as I start talking about the current situation with service provision, I do want very clearly to emphasise that there are many organisations and many individuals around the UK and around the world who are providing brilliant care to autistic children and their families. This is true for professionals within our health services, local authorities, third sector organisations, and so on. This talk is about systemic issues of care, systemic and structural issues of care, and the evidence base. It's not in any way designed to criticise or undermine the excellent work of our hardworking, caring and skilled professionals on whom, you know, current support currently relies. So let's think about care for autistic children though, you know, on a general systems level. And I think it's fair to say that that provision is often quite short term. It's a brief intervention and then it's discharge. It's also often quite reactive. It's crisis driven. There's little often that's proactive or preventative. And this is particularly the case for older children, I think, and when thinking about mental health. And the Autism Dividend Report, published in 2017 of the National Autism Project, emphasises that decision makers do not seem to understand that providing better services early on will save money in the long term. You know, so it's really important that we get those basics right. Excuse me. Provision is also often patchy. So it's patchy across different localities, and it's patchy in terms of what different kinds of provision are on offer. And there are big gaps and there are, you know, gaping holes. And Laura Crane at CRAE has done some really brilliant research which has shown that provision is a source of significant dissatisfaction for both families and for professionals. And provision is also very fragmented, even within one locality. You know, care is very often not very integrated. So I've got a couple of slides just to kind of bring this to life a little bit. So this is a quote from one of our research participants. This was taken in 2019. So pre-pandemic, this is not about the pandemic. And this is what this parent said to me. So she got a diagnosis in September. I didn't actually receive the letter until the first week of December to say she's got a diagnosis and she wouldn't be seen under CAMHS again. And that was it. So I asked them, I phoned them up to say, does this mean I can, you know, I want to go on a course. I need to know all about it. I don't really know anything about it, to be honest with you. I'm just getting on with our daily life. So they said to me, yes, you're on the waiting list for a course. We don't know how long it will take. When somebody phoned me from the research team over the summer to say, we've got a course coming up, would you like it? I was like, yes, please, finally. I just felt like, finally, because we had this diagnosis last year and I've heard nothing at all. She's not getting help or support from anybody at all. And, you know, this isn't the experience of everyone. This is not the experience of everyone that we spoke to, but this is not an uncommon experience, that people are given the diagnosis and then there's no help or support at all. I'd also like to share this diagram with you, which is a map of care provision within one borough of England. So this has been created by my colleague Amrit Bharti from the University of Leeds and the Toothpaste team, and I want to thank them for giving me permission to share this with you. So Toothpaste is a new project that aims to work out the best ways to support families of young autistic children to look after their children's teeth and prevent tooth decay. And don't worry too much about the details, you probably can't even see some of it that well, but you can see just how busy and complex this is. And this is mapping the provision within one borough. And you can just imagine, you know, firstly, it's great that there are all these things on offer, different professionals, different organisations. But you can imagine as a parent with a child who's been given a diagnosis, how difficult it must be to navigate this picture and how fragmented this is. And, you know, where do you go for help? And it's also the case that often one organisation or one professional working within one borough might not be aware of all the other services that are on offer within that borough. So it becomes very fragmented. Another feature of our provision within the UK, I think it's fair to say, is that families very often have to fight, chase, push, beg, coordinate care for their autistic child. And this is a quote that I'd just like to share with you with permission from a guy called Adam, who I follow on Twitter. And he's got a son who's autistic and has learning disabilities. And I just thought this quote pretty much sums it up. You've recently been told your child is autistic and that they will require additional support and services. Now get ready to fight. And when everyone has gone home from the offices, bury your head in paperwork and research until the early hours. Then get up and fight again. And, you know, clearly this is not an acceptable situation. Now, an important part of person-centeredness is being sensitive and responsive to the cultural backgrounds of individuals and communities. And there's been some excellent work here in the UK looking at the needs of specific communities. So I'm thinking, for example, of the work of CRAE, which has documented the needs of the Somali community in Bristol, and also the work of our Rabina Kessie, who's documented the needs of West African families living in the UK. Our Rabina has worked with CRAE. However, we are not yet very good at tailoring intervention approaches to make them culturally sensitive and responsive. And this is of critical importance in addressing the health inequalities that we know are to be found in this country and elsewhere in the world. So this is also something that, you know, we need to improve. And of course, I'm bound to say, I'm a researcher, I'm bound to point out that most provision does not have a robust evidence base, if any evidence at all. You know, and we do need our care pathways to be evidence-based. You know, do our approaches actually work? How do they work? And who do they work for? Oh, sorry, it's whizzing through a bit too quickly. Okay, so let's now turn our thoughts to where do we go from here? You know, how do we move on from the situation that we are in at the moment? So I want to share this slide with you. So this slide presents a stepped care approach model. So this has been presented by myself and colleagues recently in a working paper, which was commissioned by the NHS England Autism team and has now been shared with national commissioners. And hopefully we'll soon publish this in an academic journal so it can be shared more broadly. And in this paper, we lay out the details of this step care model and also how it can be supported by digital health technologies. Now, I'm not going to talk too much about the digital technologies today because I'll very quickly get out of my depth, but I do want to talk about this step care model. And it's interesting to see that similar proposals have also been made in the Lancet Commission on the Future of Care and Clinical Research in Autism. And some of these themes are also echoed in the Autistic Support Plan, which was published recently too. So this framework is based on evidence models for managing long-term conditions in other areas of healthcare, so managing long-term and chronic conditions. And these models have a number of common features. So they emphasise step up and step down specialist care as needed. So at the bottom of this pyramid, you can see what we need is really good, basic, universal care. So available to all families of children who have a diagnosis and all children themselves. And this is all about care that will boost understanding, communication, relationships, and resilience, really, particularly, in the weeks and months following diagnosis, but also at other key points across a child's life. There's then stepped up, targeted care for those who need it across their childhood. And I've given a couple of examples of the sorts of things this might focus on. There are lots of other things, transitions, alternative and augmentative communication. And then, of course, highly specialist support. So intensive and specialist support for those who really need that level of provision. Also critical to this model is sustained clinical case management. And that is basically health system speak for, good quality monitoring and coordination. So part of the problem experienced by families is navigating the complex picture of services and then fighting for access to those services, as I've already explained. So we need better monitoring of children's development, functioning and well-being, so that stepped up care can be offered proactively when it is needed, when it's indicated. And so that the case, so an individual child and family, their care is coordinated by the system, and therefore it's not reliant on a parent to have to act as a care coordinator. And also crucially, crucially important is that there's integration of care across providers. So our paper focused mainly on healthcare, but it's also critical that that's integrated with education, social care, leisure, and other sectors to enable, truly coordinated care. And of course, each individual component of this step care approach needs to be evidenced for feasibility, acceptability, effectiveness and cost effectiveness. And not only do individual components need to be evidenced, but pathways as a whole need to be evidenced. So how do things work in combination? So for example, if we've got an intervention that focuses on parent-child communication and relationship, how would that intervention fit with teaching and enabling children to use alternative and augmentative communication systems, things like picture cards or an app to help them communicate? How would those two things work together? So we do need to look at pathways as a whole and not just individual programs. So now I want to talk about some key issues that we need to engage with proactively, as we go about developing these care pathways and the evidence that we need to support those pathways. So the first I want to talk about is, the socio-political paradigm shift that we are part of, at least certainly within the UK and within other Western high-income countries. So over the past couple of decades, the neurodiversity movement has increasingly influenced our understanding of autism and other forms of neurodivergence. And a central premise of this movement is that variations in neurological development and functioning are a natural and valuable part of human variation, and therefore not necessarily pathological. So the neurodiversity movement and the active and passionate voices of autistic people call us to move away from a deficit-focused normalisation paradigm. So the aim of our interventions must no longer be to try and make autistic children more like neurotypical children. And, you know, that's difficult and that's complex, you know, particularly for people like myself who have been involved in autism intervention provision and research for, you know, a fair amount of time. You know, it's difficult to move from that mindset, and it's complex to do that. You know, it's so kind of embedded within our way of thinking, you know, that we must work very hard actually to make sure we're stripping out that kind of thinking and to move more to a neurodiversity way of thinking. So instead, our interventions must promote acceptance of different neurotypes. They must serve to make the environment a better fit with the needs of autistic children. And, you know, we tend to think of the physical and sensory environment, and those things are without doubt very important, but we also need to think about the social and emotional environment around the child too. And our interventions must also target those aspects of autism that autistic people actively want support with. So anxiety, you know, is one example. And the only way in which we can do this, as Laura explained at the beginning of her talk, and I know, you know, she absolutely means what she says about this, you know, we need to work in partnership with autistic people so we can ensure that autistic needs, preferences and priorities are at the centre of our work. And we are getting better at this. You know, we're doing much better now than we were even 10 years ago, but there is still a long way to go. And the final point I want to make is that we also need to think very carefully about the values, assumptions and philosophy of our interventions and our research. And also the philosophy and the values that we are passing on to families and to autistic children, advertently or inadvertently, through the care that's being given to them. Now, I recently reviewed in Open Review this paper by Monique Botha, a brilliant paper, very hard-hitting, and it's about the problematic values underpinning much autism research and the impact that that has had on them as an autistic person and as an autism researcher. You know, and we, you know, it really highlights the fact that we need to do some serious reflection on these things. And we need to ensure that the values underpinning our work are thought about carefully, are decent, and also are transparent. And as Laura said at the beginning, you know, if you want to read more about any of these issues, please do consult our open access paper in Frontiers in Psychology. And also please do check out the Autistica keynote that I did with my wonderful colleagues, Lene, Kerry and Martine. Again, I think the link should be in the chat. Okay, so following on from the previous slide, I want to talk now more about intervention targets. So coming back to my lovely friend Rory, this is him here in the pictures when he was about 4 or 5. He was just the cutest kid. And myself and other therapists working with him spent a lot of time back then when he was this age, trying to teach him things like numbers, colours, shapes. And these things can be very important intervention targets. I'm not saying we should never teach children numbers or colours, you know, these are helpful concepts. But we realised, and I'm glad that we realised, that these weren't the right targets for Rory at that time. These were not the most important things for us to be focusing on. And we concentrated much more on things like functional communication, relationships, and daily living skills. Now, incidentally, Rory still doesn't know his numbers or colours, but as you've seen, this doesn't stop him stealing the park run or, you know, funking his stuff at music festivals, you know, and it's been such an insight for me across my career to reflect on these things and to look back at, you know, and think, you know, with the benefit of hindsight, what would have been the right care for Rory and his family at that time, knowing what we know now. So thinking more about autistic priorities, we're much more aware of these now, thanks to work by, for example, the James Lind Alliance and others. Also the work of the National Autistic Task Force, and their 2019 report, which is aimed at adult social care. But I also think we can learn a lot from that report, which applies to care provision for autistic children. That said, I would say that we still don't know what the priorities are for individual autistic children. And it is a barrier that we need to overcome, really, as researchers and clinicians, to understand better the priorities for intervention, particularly for young children. And we can do this by developing better methods to access these views directly. And we can also do this by understanding the views of autistic young people and adults as they pertain to themselves when they were children. You know, so we need more thinking around this, and we need more innovations in this area. And we also need validated measurement tools that can measure the things that are important to autistic children. You know, there are huge gaps in our measurement toolkits around this. And we need tools that can measure these important priorities in all children with all different communication styles. So these are things that also need to be prioritised for future research. A related issue, is intervening with the child's development. And I think this is sometimes where things get really a bit complex, certainly in my mind. So adults who spend time with children, you know, parents, therapists, teachers, whoever that may be, spend a lot of time and energy trying to promote children's developing and learning, and trying to help their children become well-rounded individuals who can function within social groups, so families, schools, society, and so on. And I think there's a bit of a fine line, really, between us doing this with autistic children, like we would do that with all children, and us trying to change the essence of someone's neurotype, or to intervene with someone's autism when the person doesn't want that to happen. And I think this is related to getting the balance right between challenge and accommodation. So promoting development and learning through challenging and stretching a child versus changing the expectations for that child and the environment around that child to accommodate their needs. And I know that many parents worry about striking the right balance. You know, it's something that they worry they're not getting right, and they want help with to know where that right balance is. So this is something I think that we need a better framework for thinking about, and we need to give more thought to this and more research into this. And then finally, I'd like to talk a bit about adverse events. So something else we need to pay very close attention to when developing and testing interventions is adverse events. And this has been emphasised in papers recently by Kristen Bottomer-Boytle and colleagues. And increasingly we're hearing accounts from autistic people about the unintended but very real effects that early interventions have had on their lives, particularly intensive behavioural interventions. So things like interventions leaving them without coping strategies, or leaving them passive and compliant and therefore at risk of abuse. And we need to be really mindful of these things. So we must take a broad definition of adverse events as they pertain to children and their families and all aspects of their lives, and measure them as best we can within our research and within our practice, and also report those adverse events, you know, with transparency. Okay, so the third set of issues I want to talk about before moving on to some examples is thinking global. So we know that 90% of autistic children live in low and middle income countries. And there are actually very similar issues across the globe in terms of developing care pathways. Although, of course, some countries have much less resource and considerably less well-developed health systems than other countries. We've described some of the barriers and opportunities to developing health coverage for autistic children in low and middle income countries in this paper here, and hopefully you can access the link to that. It's open access. So when developing and testing interventions, we need to think about how they might work in the context in which they're being developed, but also how they might work within other contexts. And this will help in terms of developing care pathways in low and middle income countries, but it will also help in terms of tailoring care for families from minority ethnic and cultural backgrounds living within the UK. So there's a tension between homegrown and transported approaches. So homegrown approaches are those that are developed within the context that they'll be used. Transported approaches are those that are developed within one context and then tested or implemented within another context. And it would really be quite nonsensical and ridiculous not to rely on transported interventions. You know, we don't want a situation where each country has to start from scratch to develop interventions and to do all this work that needs to be done. You know, we need to be acting as a global community to produce this evidence. And actually, research has shown that transported approaches can be perfectly effective. However, careful and systematic cultural adaptation of that approach is paramount. And I'm going to give an example of this in just a moment. Another critical issue for care in low and middle income countries is cost effectiveness. So specialists like paediatricians or speech and language therapists are sometimes in very short supply. And an important consideration, therefore, is the extent to which care can be provided by non-specialists, trained and supervised by specialists, and the extent this can be done in an effective way and in a way that everyone's happy with. So the resource constraints found in low and middle income settings can force innovations that would not necessarily be considered in high income settings. So therefore we can have a bi-directional flow of learning. And I believe, you know, we should really be embracing this. So for example, non-specialist delivery evaluated within a low income country can be reverse engineered to provide more accessible and cost-effective services within a high-income country. And a final point on this topic concerns proprietary approaches. So one of the biggest barriers to progress within low and middle-income countries concerns access to intervention approaches. So access to training, access to manuals, to measurement tools to evaluate those interventions. You know, these are often copyrighted and they're often expensive and therefore prohibitive to many people working in low resource contexts. So I would urge the research community to consider this issue carefully. You know, we understand things need to be copyrighted, we understand things come at a cost, but how can we ensure that our colleagues working in low resource contexts can access our outputs so that they don't need to start from scratch, and so that evidence-based care can be provided, you know, to 90% of the world's autistic children. Okay, examples. So in this section of the talk, I'm going to talk about 2 programs of work that I've been involved with. These are big projects and I'm not really going to be able to go into all the details in the time that I've got available, but I hope to give a bit of an overview and to draw out some points that are relevant to the framework and the issues that I've just been talking about. So first up is the REACH ASD trial. So this is an ongoing project that's funded by the UK National Institute for Health Research and run by us at the University of Manchester in collaboration with King's College London and some fabulous NHS partners, as you can see on the map here, around the northwest of England. So you can see the title of the project. Now, in case you don't know, acceptance and commitment therapy is a psychotherapeutic approach that has grown out of cognitive behavioural approaches and mindfulness type approaches, and that has a pretty good evidence base for supporting people who find themselves adjusting to new life circumstances. So we were commissioned by the NIHR to develop and evaluate a programme to address the mental health needs of parents and carers following their child's diagnosis. And the NIHR recognised that there is a large amount of research pointing to poor mental health in parents in this period, and a gap in service provision and evidence to support those parents. So we have developed the programme, and if you'd like to learn more about that work, please do watch our Autistic webinar as part of the Autistic Festival last year, where we have time to go into more details. And a paper will hopefully be out soon. But basically the programme is a group-based programme for parents with 5 3-hour sessions with lots of information about autism and helpful strategies, and also some acceptance and commitment therapy components to support parents around their adjustment, their well-being, and their short and long-term stress management. So we're now running a large randomised controlled trial to test the effectiveness of the new programme, and we're chugging along quite nicely. As of this week, we've enrolled 299 participants, and that's thanks to my colleagues who are working very, very hard and very effectively on this project, in spite of the pandemic that's going on all around us and not being particularly helpful. But we're hoping to have some results from this trial in late 2023. So this trial is not a work of perfection by any stretch. As I said, we've encountered some significant challenges due to the pandemic, but I would like to reflect upon how some of this work relates to the framework that I've just presented. So this programme is situated at the bottom level of that step care pyramid. And at that level, it's all about getting the basics right. You know, good quality, basic, evidence-based, early care for families following the diagnosis. Thinking about co-production with stakeholders. So from the start of developing the intervention programme, we recognise that there are multiple and diverse factors that impact upon parents' well-being. And we wanted to understand and address many of those factors and not just one or two. So in the initial stages of this project, we carried out quite a detailed multi-step co-production process to develop a theory of change. So basically a logic model of what impacts upon parental mental health in the post-diagnostic period and how, therefore, we can support parents around this. This is just part of the theory of change that is shown here on the slide. So we work with a range of different stakeholders, parents, autistic adults, autistic parents of autistic children, NHS clinicians, and lots of other people to develop this theory of change logic model and to develop the intervention programme itself. And I'm not saying this process was perfect. We learned a lot as we were going through it, but I do think we got some things right in terms of developing the programme in this way by developing a theoretical stance, but by doing so in collaboration with parents and with autistic people, to ensure that we were addressing, addressing the key issues that were being faced by parents, and doing so in a way that was acceptable to all stakeholder groups. So coming on to the philosophy and values of the programme. So we've given a lot of thought and attention to the philosophy and values. Again, we did a lot of talking with our stakeholder representatives about this. And they told us that the approach needed to be affirming and not doom and gloom. So much about the assessment and diagnostic process could be very doom and gloom, that they wanted us to move away from that. So we take an autism positive stance, and we do that whilst also accepting where parents are at, with all the diverse and complex thoughts and feelings that they may come with, and we try to do that without judgment. And that might seem a little contradictory, but actually that seems to work really well. And I'm really pleased, with that philosophy that we've got. Another thing we've worked hard on is defining and collecting adverse events in terms of any downturn in the health or well-being or personal circumstances of participants and their families. We want to make absolutely sure that this programme is not bringing about any serious negative effects on the people who attend. And we will be reporting these in due course, with full transparency. So that's Reach ASD. Now coming on to talk about a second programme of work around the Paediatric Autism Communication Therapy, or Pact. So Pact is a communication-focused intervention for parents of young autistic children. And rather than talking through what Pact is, I thought I'd share a little video. So this video has been produced by a colleague of mine called Amanda Haydock, who's a fantastic Manchester-based Pact therapist. So thanks to her and the families featured for allowing me to share this. So it is a promotional video, so please do watch it in that light. But I think it does give a good overview of the principles and some of the methods of Pact. Plus it's got some lovely cute little kids in as well. You might need to turn your volume up because we practiced it earlier and it was playing a little bit quiet, but hopefully you can hear it okay.
What is Pact? Paediatric Autism Communication Therapy, or Pact, is an intervention that works directly with parents or carers. The intervention uses video feedback. Parents or carers take short videos of themselves playing with their child, which are then shared with the Pact therapist, who supports parents or carers to positively analyse their own interactions with their child and develop further strategies that may put lower demands on their child's processing and support them to engage. What does the research show? Research has shown that children whose parents or carers have undergone Pact show development in their communication skills over a long period of time, 6 years. This is one of the longest follow-up periods for any autism intervention and demonstrates that parents and carers can be powerful communication partners. Pact is based on decades of research into how young children develop the incredibly complex skill of communication. We know that joint attention, the ability to share attention with another person, is a fundamental building block of later interaction and communication. Shared attention and the ability to initiate communication are skills Pact aims to develop. How do children develop communication skills? Pact aims for spontaneous, intrinsically motivated communication. Communication can't be taught in the way that, say, toilet training, matching colours, or learning letters could be. True, meaningful, child-motivated communication is learned as a complex cascade of skills based on safe, trusting relationships and child-directed play within those relationships. Parents and carers are best placed to support their own child. Play is a child's work. Play is how all children learn all the skills they need for childhood and beyond. Play is intrinsically motivating for children, and this is why play is the focus and the context for Pact and other developmental interventions. What does Pact help to develop? We know that a child's own interests and passions are the key to shared attention. There are many ways that parents can support engagement in their young child. Pact supports a deeper understanding of why different strategies are helpful. It highlights when parents or carers are in shared attention and when they feel most connected to and engaged with their child. After discussion about these shared moments, parents or carers make goals based on what they have seen in their videos. Pact aims to place as few demands on the child as possible. It is a developmental intervention and so does not aim to teach a child any particular skill, but instead aims to promote overall communication development at the child's and family's own pace. What happens in Pact intervention? Pact involves 12-hour-long sessions between parents or carers and the Pact therapist over a 6-month period. Research has shown that this is enough time to be able to embed the learned strategies into daily life. Pact can be used with children right across the autism spectrum. What do parents think about Pact? Pact can lead to parents and children feeling more connected and in tune with one another, feeling more positive about autism and sharing joy together. Pact can change the lives of the whole family.
Okay, I'm just going to cut that off there because I'm aware of time, but I think, you know, that brings it to life a little bit for you, hopefully. And I've got some slides here that depict the programme of work from its inception to where we are now with regards to Pact therapy. So this slide is about the work that we've been doing in the UK. So just to pick a few bits out, you know, it all started with a PhD by Catherine Aldred, which was a pilot study of Pact, published back in 2004. The Pact trial ran between 2006 and 2010 and was the first large trial of its kind. You know, we didn't know whether we'd be able to recruit, whether the randomised design would be acceptable to parents at that point. It was a bit of a step into the unknown, but we showed that, you know, large randomised trials of autism interventions could indeed work. We carried out a 6-year follow-up study, which showed long-term improvements in child communication and reductions in autism symptoms for those who had accessed Pact. We've also measured parent-nominated priorities in terms of family experience, which showed that families who had engaged in Pact had improved quality of life. And we've also done a qualitative analysis of parental perceptions and experiences of taking part in the therapy. So implementation of Pact is now happening within the real world, so within several UK NHS trusts, and it's also being provided by independent providers such as Spectrum Connection, who provided the video that we've just seen. So how does this programme relate to the framework that I've discussed? So like the REACH programme, this is situated at the bottom of the Step Care framework. So it's something that could be offered to all families of young children on the spectrum. Thinking about neurodiversity consistency, as you heard in the video, you know, I do believe the approach is fairly neurodiversity consistent. It focuses on changing the parent and not the child, and aims to improve the social and emotional goodness of fit around the child. Now, I'm pleased that we've measured family-nominated outcomes, so parent-nominated outcomes, and the views of parents of their experience of Pact. However, the programme was not developed in partnership with autistic people. You know, that wasn't done in the early 2000s. Nor have we measured autistic priorities, autistic prioritised outcomes. And I know anecdotally that many autistic people like the approach, but I do think it would be important for us at some point to carry out some research into the views of autistic people on this therapy, or indeed the views of children who have participated in it and are now young adults. Thinking about outcomes, you know, all of our papers have looked at parent-child dyadic communication, and that's clearly a really important outcome. We've also included as an outcome autism symptoms or autism severity, which is a more complex and potentially problematic outcome because, you know, it's such an amalgam of different things that we don't really know what might have changed actually as a result of the therapy. And also because, you know, reducing autism generally is a bit of a problematic concept, both conceptually and also ethically when trying to align oneself, you know, with a neurodiversity paradigm. And this is something that we've started to think quite carefully about. So this slide focuses on the work that has happened in South Asia. So we've done some brilliant work in South Asia, mainly led by colleagues working for Sangath. And they've done a programme of work in which they've taken the Pact approach and adapted it through careful adaptation for use in South Asia. They've carried out 2 pilot studies of this adapted intervention that's called Pathplus. And now we're carrying out a large randomised control trial of the Pathplus therapy as it's being delivered by local community health workers working on the ground in Delhi. And we anticipate the results of that large trial in a couple of years. So this is a really nice example of a successfully transported approach. And this has been due to the careful adaptation work that our colleagues in India and in Pakistan have done, you know, paying close attention to the cultural, linguistic and practical issues of implementing this therapy in South Asia. And they've also paid really close attention to the training and supervision cascade, which has meant that this intervention can be delivered by non-specialists within India. And that can happen, you know, with good fidelity. You know, we've shown this a few times. And we've also shown that the therapy results in some similar outcomes to when it's delivered by specialists in the UK. The Pathplus intervention is considered a separate intervention to Pact, although of course it's very closely related. And therefore there are separate proprietary arrangements in place to ensure that this intervention can be implemented and scaled up, you know, at low cost within South Asia. I've just got some really brief conclusions because I knew I would be running out of time. Sorry that I've gone over time. You know, there's clearly a lot of work for us to do to develop care pathways in the UK and around the world. We need to get smarter. We need to get more agile in developing these quickly, providing the evidence that we need and turning that evidence into practice. But there is a lot of good work happening around the world and moving us in the right direction to make that happen. And finally, just to say thank you to you for listening, for CRAE, for having me, and to all the people who have contributed to the things that I've shared within this talk today.
Fantastic. Thank you so much, Kathy, for that brilliant talk. It was
Sorry,
lovely.
I've gone over, Laura. I apologise for that. I knew I would do. And we were a bit slow to get started, unfortunately.
But honestly, it was such a pleasure to hear kind of more about your values and your philosophy and your commitment to kind of developing a robust evidence base, and just to hear about your really impressive work, you know, not only taking this intervention work kind of on an international scale, but also running a big randomized controlled trial during a global pandemic, which, you know, is just incredible.
Yeah. And as I showed on that last slide, all of this work has been, you know, done by huge teams with loads of people, brilliant people working really hard. You know, I am just a very small cog in the machine.
Well, we've had lots of questions, so we're aware it is 5 o'clock, so apologies to those who have to leave the webinar now, but we are going to stay for 15 more minutes and we'll keep the recording going. So if you'd like to catch up on the conversation later, we will be posting it on our CRAE YouTube channel. But we've had several questions come in. So one question is, how do you think we can do a better job identifying the priorities of autistic people to guide interventions, and particularly getting the views of autistic people who might be non-speaking, for example, or minimally verbal?
Brilliant question, you know, and something that we really need to be giving much more thought to and doing much more research into, you know, and I'm really keen to do that and to work on any projects that are moving us in that direction. You know, it's clearly, you know, a challenge for us to know how to access the views of young children, particularly those who are at earlier levels of their communication development. You know, but we need to start getting innovative. We need to start developing better methods to do that, to access the views of all people, you know, who we can't use traditional methods with, you know, interviews, questionnaires or whatever. You know, I'm very interested in how we can use augmentative and alternative communication systems for that. So one example is Talking Maths, which is a system that I've recently done training in, which uses picture symbols to allow somebody to share their views, usually about their own care. So that's one example. You know, but we need other things as well. And I also, as I said in the talk, I also think it's really important for us to be talking to young adults or adults about their experiences of early intervention when they were younger, or to reflect back on their earlier years around what would have been important for them to have received care and support with when they were younger. You know, and I think it's really important for us to do that. And, you know, I find I particularly enjoy working with autistic parents of autistic children, because they can, you know, they understand the life as a parent, they also understand the life as an autistic child, both through their own children and through their own experiences. So I often find that they can talk from lots of different angles and just share really, really valuable perspectives.
Well, actually, in saying that, you've preempted one of our questions that has come in. So obviously you spoke about interventions, which is about parents communicating with their autistic children. And we had a brilliant question come in asking, do you see any differences when you have autistic parents communicating with their autistic children? So I don't know if any of your participants who've taken part in the interventions have been autistic themselves, and if they've been able to share any reflections there.
Yeah, again, a really great question. And, you know, often, you know, I think it's quite a common thing, particularly, you know, more recently, that when parents have a child diagnosed with autism, they reflect on their own, you know, maybe some difficulties that they've had within their own life, and also reflect on whether they might be autistic themselves, and maybe self-diagnose, or maybe go and seek a diagnosis for themselves. And we saw this with Christine McGuinness. I don't know if some of you saw that documentary that was on the BBC recently, which is exactly what happened with her. Really insightful. Interestingly enough, within the original Pact trial, we didn't have any parents that we knew were autistic or that told us that they were autistic. In our more recent trial that I've not talked about, called Pact G, that we should be publishing soon, we did have some parents who self-identified as autistic or had a diagnosis of autism. And, you know, the therapists really enjoyed working with those parents, and actually didn't report any kind of significant, I don't know, differences in working with those parents compared to working with neurotypical parents. And obviously sometimes parents like that, like Christine McGuinness, you know, have sometimes a more natural and intuitive understanding of their children than neurotypical children parents might, who might sometimes, you know, take longer to kind of come to terms with the diagnosis and to kind of really understand their children. Talking about REACH ASD, so the trial of the Parent Post-Diagnostic Programme, we've actually had quite a lot of parents taking part in that who, again, self-identify or have been diagnosed with autism. And, you know, that's been brilliant. And we've spent a lot of time thinking and talking about making sure that the group is accessible to parents from all neurotypes. And we've just started doing some interviews with some of the parents that have finished the programme. And we're sampling some of those parents so that we can really explore, you know, how was this group for those parents? Did they get what they wanted and needed from it? How was it for them also, perhaps being in a group with some parents who might be struggling with the fact that their child's autistic? You know, how does that feel as an autistic person in that group? So it's something we're quite mindful of, and we want to understand more about. I hope that's answered the question. I've probably gone off at a tangent.
Absolutely. No, that's really, really helpful. Thank you, Kathy. We've had a few kind of practical questions come in about the intervention. So in terms of Pact, for example, we've had a question about who actually delivers Pact to parents of autistic children, and also a question about how parents can access interventions like REACH ASD and Pact.
Okay. So I'm just trying to unpick because there's a few different questions there. So yep. Who delivers Pact? Yeah. So within the UK, Pact has been designed to be delivered by a range of different professionals. Mainly, historically, it's been delivered by speech and language therapists, but more recently, it's been delivered by psychologists, assistant psychologists, teachers, and so on. You know, so a range of different professionals. Within, obviously, the work that we've been doing in India and Pakistan, the adapted Pact, so Pathplus, is delivered by non-specialists, so people who don't have any prior exposure to autism or any particular knowledge or understanding of autism or child development. You know, we've shown with the right supervision and training that they can deliver the therapy well. How can people access it? That was the second part of the question, wasn't it? So as I said, Pact is now being implemented in some trusts around the UK within the NHS. You know, it's taking time to make that happen, but it is now happening, certainly in Greater Manchester, that there's now a big programme to make sure that Pact is available as kind of standard care. Again, it takes time to make things happen. But it's not yet universally available, you know, and it will take time to make that happen. There are some independent providers, so like Amanda Haydock from Spectrum Connection, and she has got national lottery funding to make the intervention available at low cost to families, to low-income families, which is fantastic. So there are lots of different initiatives going on around the country, but you know, I do get a lot of emails from parents, and I'm not always able to guarantee that they're going to be able to access Pact if they want to, because it just takes time for things to filter out, unfortunately. And that, you know, a more general point is that we need to get better at this. You know, we need to get better at producing evidence quickly and efficiently, and then turning that evidence into practice much more efficiently as well.
Brilliant, thank you. And you touched upon there about obviously parents accessing Pact, and we've had a question come in about parental isolation, and if that's anything that your research has touched on. And I wonder, you know, if you spoke a bit about parents being at different stages of their journey, and in terms of their levels of acceptance and understanding, you know, is there something on offer, or could there be something on offer, I guess, for parents who aren't ready to engage in that group discussion or find that aspect of it difficult? Or how would you, I guess, you know, thinking about the fragmented care pathway, the difficulties access and support, what about these parents who really can't access these kind of group-based programs?
Yeah, and you know, it's a really important thing for us to think about in terms of person-centeredness, and it's one thing that worries me a little bit, really, because I'm a fan of person-centered care, as you've heard. But you know, when delivering a group-based program with, say, 10 parents, actually how person-centered can you be, you know, to the needs of one individual? You know, we've got 2 brilliant practitioners delivering our program, and you know, they do absolutely everything they can to try and make sure that different people's needs are being met. But you know, you can't tailor everything to the needs of one particular individual. So I do worry about that. I also worry about, in terms of person-centeredness, kind of cultural sensitivity and cultural responsiveness, because again, when you've got a group of parents from all sorts of different backgrounds, you can't tailor your approach to, you know, one person's needs. So I'm actually working with a clinical psychology doctoral student starting from this year, who's going to be looking at our intervention and how we can try and ensure that it is as culturally kind of sensitive and responsive as it can be. So that's something I'm keen on exploring further as well. But no, absolutely, you know, there are parents who don't want to or aren't ready to engage in a group-based approach. And therefore, you know, within clinical provision, there would need to be something more individualised for those parents. And it can also be a little bit tricky within groups, where you've got parents at different places along that journey, you know, where you've got parents who are really struggling with accepting the diagnosis, or really angry about it, or experience a lot of kind of sorrow or grief, you know, and that is the truth of some people's experience. And then you've got parents who really don't feel like that and are kind of quite accepting and you know, kind of at ease with it all, you know, and just kind of responding to all those different experiences. And you know, that's what we try to do within this program. We try to meet people where they're at, and ACT is really very well, acceptance and commitment therapy is quite well designed to help you do that. But that's not to say that parents might find other parents, you know, stories and experiences upsetting or, you know, difficult to hear.
Absolutely. We've got so many questions coming in. I'm really sorry to everyone who we've not been able to get your question asked. I'm going to pick one more, kind of at random here. And this is about, so you spoke a little bit, and it was really interesting to hear this actually, how the kind of aspects in which you felt that Pact weren't quite aligned with the neurodiversity perspective, particularly in considering your outcome measure of the ADOS, which was really interesting to hear. And there's a question about whether you think there might be any ways in which the parent programme that you've developed for Reach ASD might not be consistent with the framework that you've been talking about. Is there any area that you might like to develop further, or that you're planning to develop further in terms of Reach ASD, so it is as well aligned with your kind of ethos and philosophy as possible?
Of course there are things, you know, absolutely, and you know, it's good to reflect on those things and to, you know, be transparent about them. And so firstly, to go back to the person-centeredness, I think that is one thing, you know, with any group-based approach that makes it difficult to be responsive and person-centered and tailor your approach to individual needs, which is slightly at odds with this framework. Something else I think is relevant is that, you know, again, we spent a lot of time thinking and talking about this in the early stages, about whether the group should be co-delivered by A, a parent, and B, an autistic person. And in the end, we moved away from that. And that was because what clinicians within autism diagnostic and intervention teams were telling us was that, you know, that would make it more difficult for them to deliver this programme. You know, that they'd tried that in the past and they'd come across all sorts of different barriers in terms of paying people, in terms of, you know, the governance that they have to go by and so on. So there were lots of practical reasons in the end that we decided not to do that within the trial. Although, of course, within other contexts, absolutely, this programme could be delivered by people who have lived experience as a parent or as an autistic person themselves. We also had a few concerns about an autistic person delivering the programme and how that might be for them as somebody hearing some of these difficult thoughts and feelings from parents, you know, how that might be for that individual, and also the impact of that on parents' abilities to be honest about their true feelings. You know, whether people might feel that they couldn't share some difficult thoughts or feelings. And we do believe it's important that people are able to share those, because that's the only way that people can move on. You know, even if we find that uncomfortable to hear, you know, we have to meet people where they're at, and we have to work with whatever their thoughts and feelings are at that time. So there were a lot of different things that we thought about and considered, and that, you know, I'd like to give further thought to really in the future, you know, around those things, and around the views of the children of the parents taking part, which we've not given much consideration to either. And it's tricky because the children are newly diagnosed. They might not always understand their own diagnosis. They might not, you know, they're in early stages, you know, even for children for whom they may be aware of that diagnosis. We felt it wouldn't be appropriate to have conversations with them, really. So we're not doing that, but that's, again, something else that we could think about in the future.
Yeah, I think it's all a work in progress, and it's really nice actually just even to see some of the changes in the kind of philosophy and approach, just even from Pact to Reach ASD, for example. So, and it's great to hear that you're kind of thinking about those things, and, you know, who knows, you know, 10 years in the future, we might see a very kind of revolutionary approach in that regard as well, embodying some of those things that you just mentioned.
That would be my hope.
Thank you so much, Kathy, for that really brilliant talk and for answering the questions. As I said, apologies to all of those whose questions we've not been able to put to Kathy. We did have an enormous amount come in, which I think was a testament to how interesting the talk was. Before we finish, I just want to say a big thank you to the CRAE team for all of your support behind the scenes, and thank you to everyone who's joined today. Do take a look at our website, crae.io autistic.ac.uk for details of future webinars that feature a host of really wonderful researchers and advocates. And our next webinar is by the brilliant Monique Botha, who Kathy mentioned, who's from the University of Stirling, and their talk is about the construction of autistic people by autism researchers. And that is on Thursday, the 3rd of February at 4 o'clock UK time. We really hope to see you there. Thank you, everyone.
Thank you, Laura.